So let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and a writer. I've been working with CCF for 10 years. In fact, it may be over 10 years now. I was saying 10 years last year. I think we started together in 2011, and it is now 2022, which kind of seems unreal. But I've been working with them through that span of time to create video content like this, like live video series, but also produce videos, treatment-based videos, patient-centric videos, all kinds of films and videos that we create, but all with the same mission in mind, and that is to spread awareness, educate people about neuroendocrine tumors. We have a whole extensive database, a library of videos. So I encourage you to check that out after you watch the show today. If you're dealing with something in particular, chances are we have covered it in a video. And if you're new to the show, I want to say welcome. If you are a regular, let me check. You're probably already saying hello and where you're from. And I see that: Wisconsin, British Columbia, northern Minnesota. It must be cold up in some of those places. So yeah, if you're new, a major benefit from the show and the net community is the community itself. The experts and the specialists obviously have the information that you need, but so much is gained from the shared stories and shared experiences from the other patients and caregivers and support group leaders in the community. So absolutely tell everybody, you introduce yourself. They will welcome you with open arms, and I promise you it will be beneficial to your life. Before we move on with the show, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Folks, without their support, we wouldn't be able to do the show. But we have this disclaimer from them that we like to say at the top of the program, and that is that the opinions expressed by our guest presenter, as well as the questions asked by the audience that you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information expressed in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. All right, so disclaimers are always lengthy and wordy, but the takeaway is we're going to give you some great advice and answers to your questions today, but by no means do we or our guest know your specific case. So take that advice, take those answers to your home team, which does, and make the best plan and path forward for you, because if we know anything about this disease, each case of it is unique, and therefore each plan and path forward is as well. Folks, today I would like to welcome Dr. Daniel Lee. Dr. Lee, how are you?
Good. How are you today, Rain?
I'm doing well. Thank you so much for being here. For those that aren't as familiar with the work that you do in the net community, tell us a little bit about yourself, where you work, what you do, and the role you fill in the community.
Sure. So I am Chief of Nuclear Medicine at Oscar Medical Center in New Orleans, Louisiana. And I am director of the PRRT program, the peptide receptor radionuclide therapy program at NOLA-NETS. So you may know some of my partners who have also been on this event here. So my current and former partners, Dr. Mary Maluccio, who heads up our NOLA-NETS program, her other surgeon partner, Dr. Philip Boudreau, and
Absolutely.
Our former medical oncologist, Rob Ramirez.
Absolutely.
And I'm the immediate past president of the Society of Nuclear Medicine Therapy Center of Excellence. And so you may also be familiar with some of my colleagues, Dr. Tom Hope from UCSF and Dr. Eric Mitra from Oregon, who has also been on this program.
Absolutely. We just had many of these people very recently. And so that is part of the community is you see a lot of familiar faces, even though the community is growing. But yeah, definitely shout out to all of those doctors. I have to say that the NOLA-NETS program is so impressive to me. I've gotten to spend some time there. I was mentioning this to you, Dr. Lee, before we started recording, before the pandemic hit, when I was traveling a lot for CCF. And so I got to go and do some videos there with Dr. Ramirez, et cetera. And yeah, it was really impressive to me to see like what felt like a whole wing of a floor that was dedicated to NETs, because as I know a lot of the patients probably experience, it's not necessarily that way at all the hospitals. So we'll probably talk about why a specialty center, a net center is important. But we'll also probably talk a lot about PRRT, which you've already mentioned. We get questions every week, lots of questions about that, folks. So now that you know a little bit about Dr. Lee, you can understand where you're really going to get the most value from him and the questions that you can answer. So go ahead and start sending those questions in. We've also alluded to some of the guests that we've had on the show that are colleagues of Dr. Lee, and also want to take a moment to give a shout out to some other guests that we've had. Today is actually National Women Physicians Day, and I just want to say, major love, major support to all the amazing women net physicians that we have in the community that have been on the show and that haven't. We appreciate you, folks. So last couple of things before we start the show. We want to get as many people here as possible to be a part of this one-on-one interactive session. So if you know someone that should be here or would benefit from Dr. Lee's knowledge, go ahead and tag them in the comments. Let them know the show is going on. Get as many people here as possible. And the second ask that I have from you all is, if you see a question in the sidebar that you also have or you're interested in the answer to, you can simply, like right under it, it has the option to like that question. You can like it, and what that does for me effectively is it upvotes it. It lets me see there's a demand for that question. We get a ton of questions throughout this next hour, and inevitably we don't get to them all. So that lets me know if 7 people have that question, it's high demand. I'm going to make sure to get it across. Now, if we don't get to your question, if you're one of those, I highly encourage you to reach out to CCF. You can message them here on Facebook, or you can visit their website. We will have the show posted on Facebook as soon as this is done. It will live here under the videos tab, so you can always replay it. And starting Monday, we will have it. We will have it on YouTube for those that don't have Facebook. All right, so start sending in your questions. Hello, Ritva from Finland. We got Finland in the house. I love how far this program reaches. It's not super late in Finland, but sometimes we have people from parts of the world where I'm like, shouldn't you be asleep? You're watching the show live. That must mean we're doing a good job. That makes me feel great. Yeah, go ahead and start sending in your questions. We are going to start the show. And as I suspected, Dr. Lee, we already have PRRT questions coming in, so I'm gonna go ahead and start taking some of those. From Janace, who I've seen up here a couple of times, what percentage of PRRT patients benefit from it? And what are some of the most common benefits? So this is a good kind of like laying down some groundwork.
Well, thank you for that question, Janice. The majority of our patients benefit from the treatment. And by benefit, we that arrest of the disease would be considered a benefit. So we would judge this by scans, pre-treatment scans and post-treatment scans. If they look more or less the same, then we may have stopped what had been up until that point a progressive disease, which would have been the indication or reason for treatment with PRRT. And ideally, we would see a complete imaging response where the tumor would melt away. Unfortunately, we don't see that very often. We're treating a wide variety of diseases, so we lump them all together and call them neuroendocrine tumors. But they're actually a spectrum of diseases, and even disease that start out relatively well-behaved can change gears over time and exhibit more aggressive biological behavior. And so we may have some benefit as far as symptomatic relief. So carcinoid syndrome is something that negatively impacts one's quality of life. We have patients who basically live in or basically next to the bathroom from frequent episodes of diarrhea, flushing, low blood pressure. All these things definitely impact one's quality of life and ability to work or even just to exist. So for those patients who are extremely symptomatic, most of our patients receive at least some symptomatic relief.
Good to know. Thank you so much, and thanks for your question. Next question from Jolene. This is an interesting one. Is there any crossover between lymphoma diagnosis but symptoms present as a NET or carcinoid syndrome? Second question: does a therapy exist that overlaps to treat lymphoma and neuroendocrine tumor or carcinoid syndrome?
Well, that's an interesting question, Jolene. Not that I am aware of. The symptoms of neuroendocrine tumors are non-specific, which is why the diagnosis of some type of neuroendocrine cancer or tumor can be delayed by several years. So if patients present with vague GI symptoms, discomfort, frequent diarrhea, you may have workup, colonoscopy, various kinds of imaging studies that are inconclusive for many, many years before the disease kind of declares itself on some type of scan or in some type of blood work. And so I think it's possible for there to be some overlap of symptoms. With lymphoma, we tend to see most commonly enlarged lymph nodes. They could be in the neck, in the armpits, in the groin. That might be apparent to the layperson, to the person herself. On scans, we might see the lymph nodes. So if you have an ultrasound or a CAT scan or a PET scan, we might see something and say, there might be lymphoma here. As far as the symptoms go, there are what are referred to as B symptoms, which is like drenching night sweats and unintended weight loss over a period of, I think, 6 months. And those things altogether would be pretty suggestive of lymphoma. But again, those things are also non-specific and can be related to other conditions. So we talk about a differential diagnosis in medicine, which is kind of a list of possibilities of diagnoses that might explain something. And ideally, you could find one thing that explains everything. Sometimes that's clear. Sometimes that's not when you have non-specific physical exam findings, non-specific symptoms, which is why quite frequently the diagnosis of a carcinoid tumor or a neuroendocrine tumor is delayed by many, many years for our patients.
Got it. Thank you, and I appreciate your question, Jolene. Hopefully that helped, and let me know. And actually, I see your account as Jolene and Jeff, so I'm not sure which one I'm talking to, but thank you both for being here. Okay, so next question. This is from Lynn. Lynn says, and a few other people have this question as well. When will I know if a bland embolization on a liver worked? What imaging is used to get a good look at that?
Bland embolization. So this is a little bit out of my wheelhouse, and this would probably best be answered by an interventional radiologist or interventional oncologist. Commonly, we use CT and MRI to follow liver tumors. And so there's a variety of different interventions, what we call liver-directed therapies, bland embolization being one of them. And I really don't know, so I don't want to guess and give you a wrong answer. So I would suggest that if you're considering this procedure, or if you've had this procedure, you could speak to your consultant, the interventional radiologist, interventional oncologist. I would be providing not the best informed opinion if I rendered one here.
Got it. Appreciate that. Okay, next question from Mary Helen. Mary Helen says, I was diagnosed with carcinoid 6 years ago. I have severe syndrome and the most carcinoid tumors of anyone at MD Anderson. Wow. I had PRRT and it didn't affect the syndrome, although it did kill some of the tumors. I had a kidney failure, which they weren't expecting. And after 2 years, the tumors grew back and were very aggressive until December. The question is, I'm interested in other treatments that would help with this syndrome because it's very severe. Anything other than the PRRT, which Mary Helen has had?
Well, there are other kinds of drugs that can be used, chemotherapy. We've had some of our patients receive treatment with immunotherapies. So it's a new class of agents that are effective for a variety of tumors. But in fact, we have had somebody who I think went to Anderson, Mary Helen. And I'm sorry to hear that you're suffering so badly. But we do see this sometimes where patients are extremely symptomatic, or what we call syndromic. I understand that can be very debilitating. And we do see that where tumors are relatively what we call indolent or slow growing. Biologically, we would call them well-behaved, where they progress very, very slowly. And so patients can live for a very long time with the tumor. Unfortunately, if they're also symptomatic or syndromic, they may also suffer for a very long time, which seems to be what your situation is. And we have had patients who've received immunotherapy and seen dramatic responses after they didn't respond to conventional PRRT. Also, there are different kinds of PRRT. Here in the States, the only FDA-approved indication is one labeled with lutetium-177, and that's what we call a beta emitter. And so that's a particle that's released from the nucleus, and it's basically an electron, which, if you may remember from chemistry, compared to the entire size of an atom is minuscule, it's tiny. And we have other kinds of beta emitters that emit stronger beta particles, so may be able to treat larger tumors, which isn't necessarily the answer. We have also some investigational PRRT agents using alpha emitters. So going back to chemistry, an alpha emitter is basically a helium nucleus. So this is maybe getting a little bit too in the weeds, perhaps, but it's 2 protons and 2 neutrons. And so relatively speaking, the mass of an alpha particle is 7,000 times as large as a particle. So that's kind of like the difference between like a BB and a bowling ball. And so the alpha particles can do much more damage to tumor cells. And so we have some trials. We're about to launch a trial here at Ochsner involving alpha particles. And we're hopeful that patients who receive this therapy will receive a good response. There are different eligibility criteria for these trials. The current trial that we're about to launch involves patients who are PRRT naive, meaning that they've not been previously treated with PRRT. So someone like you who has previously received PRRT would not be eligible for this. I'm hopeful that we will be able to start a trial for patients who have been pre-treated, who have what we call refractory or resistant disease to other forms of therapy, including PRRT with beta emitters like lutetium-177. So I'm hopeful that you can find an answer, Mary Helen.
Thanks for your question, Mary Helen. And Dr. Lee, coincidentally, our next question is from Skip, who says, when do you think PR or alpha PRRT rather would be commercially available? Any thoughts or predictions on that?
I am hopeful that we will be able to begin it within the next few to several years. So alpha emitters are relatively new in nuclear medicine as far as being commercially available. The first commercially available alpha emitter was radium-223, which we use to treat bone metastases. And the label indication for that is for patients with metastatic castrate-resistant prostate cancer, which I wish weren't the case because it's a very narrow indication. I wish it were available for anybody with bone metastases, which would open up the potential pool of patients who could benefit from that. And that was gratifying for me because when I was a resident in 2002, 2003, 2004, alpha emitters were investigational. And part of the issue with alpha emitters is that they're dangerous, they're radioactive, and the potential for internal contamination from spills is very high because they're very hard to detect. And so, for instance, if you spilled some type of alpha emitting radiopharmaceutical on the tabletop, you could throw a sheet of paper over it, and even with the most sensitive instrument designed for detecting alpha emitters, you wouldn't be able to detect it. And production and scaling production of alpha emitters is an issue that we need to face as a specialty, working with our radiochemists to be able to scale up production. So as you might imagine, the facilities that produce the different alpha emitting agents are few and far between, requiring very specialized personnel, physicists, radiochemists who can create these things. And then also, and we don't use as a rule, alpha emitters by themselves. They have to be attached to something, what we would call the maybe active ingredient, so that the active ingredient could home in on the tumor and bring the radiation with it, so you could deliver the radiation to the tumor. So I am hopeful that within the next several years, we'll be able to see additional alpha emitting radiopharmaceuticals to treat a variety of diseases, not just for neuroendocrine tumors, but for other diseases as well.
Got it. Appreciate that, Dr. Lee. And thank you, Skip. Good to see your name again, my friend. Folks, if you are just joining us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And we are here today with Dr. Daniel Lee from Ochsner. And we've talked a lot about PRRT, nuclear medicine. So go ahead and continue sending in your questions, and we've got plenty of time left. Next question comes from Marilyn. Marilyn says, if PRRT has kept NETs stable for 2 years, but there are now some new bone mets, is there a protocol for treatment?
So I think it depends on the extent of disease, if it's only in the bones or if it's in the soft tissues and the bones. So potentially the patient could be retreated with another round of PRRT. So we've been doing that for some of our patients in Europe and Australia. I think they have more experience with retreating patients. So in addition to getting the original 4 cycles of lutetium-177 dotatate, we've been giving patients an additional 2 cycles at a time to see how they do. Okay. So that would be an option. If somebody had bone-only disease, one might consider some other treatment. So I mentioned the radium-223 that we use to treat prostate cancer patients. Unfortunately, that probably wouldn't be able to be used for somebody with neuroendocrine tumor. But we do have other beta-emitting agents to treat patients with painful bone metastases. The advantage of the radium-223, since it's an alpha emitter, is that we have good data to show that not only is it good for durable pain relief, but in the trials, the phase 3 trials for treating prostate cancer patients, there was a modest advantage in overall survival, median overall survival, for those patients who received the radium-223 compared to those patients who did not, as well as a delay in the first symptomatic skeletal events, such as pathologic fractures. So I'm hopeful that someday soon we'll be able to expand the label indications of radium-223 so that we could treat additional patients, including neuroendocrine tumor patients who might benefit from that kind of treatment when they have bone-only disease.
Got it. Thank you very much. Next question from Jim. I have no receptors, so limited treatment options. For patients without the receptors for whom treatments such as PRRT are not an option, does this ever change over time? Or to simplify, pardon me, have you ever seen a patient without the receptors eventually develop them down the road?
So, Jim, that's a good question. In neuroendocrine tumors, I don't believe I've seen that to be the case. What we tend to see is what we call well-differentiated tumors. And by differentiated tumors, we mean that the tumor cells look like the cells that they originated from. So if we look at them under the microscope, they resemble the organ of origin. So if it's a pancreatic neuroendocrine tumor, then the tumor cells would be recognizable as pancreatic cells. Not entirely normal, but of pancreatic origin. Mm-hmm. And what tends to happen is that tumors tend to, over time, given enough time and opportunity, they will switch gears and they will become what we say is dedifferentiated or less differentiated. And so for somatostatin analog therapies like octreotide and the long-acting version, lanreotide, which many of our patients are on, as well as for PRRT, which is basically the same active ingredient with the radioactive label. To see the tumor, to treat the tumor depends upon expression of what we call somatostatin receptors on the cell surface. Mm-hmm. So the targeting mechanism for the active ingredient. And as the tumors change their biology, as they become less differentiated, they resemble the organs that they originated from less. So as they start becoming unrecognizable, they tend to not express or show the somatostatin receptors, which is the critical mechanism for our drugs, whether it's lanreotide for symptomatic management in between, or for PRRT, or even for the PET scans, the dotatate PET scans that we use. They all have the same active ingredient, but if it can't match up with the receptor because it isn't there, then the somatostatin receptor drugs that we use to treat, radioactive or not, or to image, become less effective. So there's kind of a spectrum where if you have well differentiated on one end and poorly differentiated on the other, as they shift, then the tumor will show up less well on our dotatate scans and may show up better on FDG PET-CT scans, which is where we use an analog of sugar to see the tumors. And so when we start seeing the tumors on the FDG PET scans, we know that the tumors are going to behave more aggressive. And this is not mutually exclusive either. The patient have both well-differentiated disease and poorly differentiated disease as part of their overall tumor burden, which means that if we treat them with lanreotide or PRRT, they're more likely to get a good response from the well-differentiated or better differentiated disease, and not likely to get a good response from the poorly differentiated disease. So it gets complicated. Mm-hmm. And if it's not clear, I could try explaining again, but if it seems complicated, it's because it is.
Fair point. Fair point. Folks, we're looking great. We're about halfway through the show. We have over 100 people in the room, which is always nice to see, and it continues to climb. I think Dr. Lee is being very thorough and clear and very helpful. And if you agree and you're getting some value from the show today, just type value in the comment section. Let me know that you are enjoying it and that you are understanding everything that he's saying and it's helpful. We have a next question from Raphael. Raphael says, and I knew this question would come up, it often does. What is the right time for to use PRRT? Is it a first or early therapy, or is it a last and later option? We talk about sequencing often. What are your thoughts?
Raphael, that's a fantastic question. And to be honest, we don't know. So the way it's been studied so far is something that comes after we've seen progression already on conventional therapies such as somatostatin analogs, either octreotide, short-acting or long-acting lanreotide. And so as is common for radiopharmaceutical therapies, they're often left toward the end of a disease course. And so what I think would be interesting would be to study it earlier on as a first-line therapy, as opposed to something that comes later in the course of disease. And so, we're starting to develop the data from different trials for how to treat diseases. And so that's a good starting point, but we need more data and we need better data, including looking at PRRT closer to the beginning, when potentially, we don't know, it might have a greater effect in the course of disease.
Got it. Thank you. And thanks, Raphael, for your question. Again, this is one that is definitely being discussed in the community. I'm aware. Moving along, Nida, let me know if I'm pronouncing that correctly. In my most recent colonoscopy performed in December, a second tumor was found, which is scheduled to be removed next week. Since this is the second occurrence in 3 years, is there any value in having a PET scan done to see if there may be others outside the GI tract?
I think so, absolutely, because the tumor can go to other places and may be occult by conventional imaging modalities such as CT. So my radiologist colleagues are often skeptical about findings we see on PET scans when they look at the CT and there may not be anything there. And so they may not appreciate the difference between nuclear medicine modalities, which are looking at function, which may precede changes in structure, which is what we're looking at with radiologic modalities like CT or MRI. And which is not to say that one couldn't start seeing these things depending upon how you'd perform the MRI or perform the CT. And that's not also to suggest that PET is superior to all modalities. PET also has its limitations. So for instance, sometimes we have challenges seeing tumor in the liver that we can see better by MRI with a particular kind of sequence. And if the tumors are very small and the background activity in the liver with the current tracers that we're using creates a problem, then the MRI may show things to better advantage. Now, one piece of good news is that in the pipeline, we're working on new kinds of tracers, PET tracers, for neuroendocrine tumor imaging that may have a better profile as far as how much background activity there is in the liver. Mm-hmm. So the high background, as I mentioned, can obscure those smaller lesions, those lesions that aren't as hot, what we call hot on PET, meaning that they may have a lower level of expression of the somatostatin receptors. So they'll be harder to see on PET. But if the newer kinds of tracers show less background in the liver, then that may allow those other liver tumors to show up better and be more conspicuous on our PET scans. So hopefully we'll get those and start using those within the next several years.
Got it. Thank you so much. Next question from Amy. Amy says, I have a grade 3 neuroendocrine that was removed 3 years ago from the small intestine. It was also in 5 nearby lymph nodes, and I do 5 HIAA and chromogram in every 3 to 4 months, and have had scans as well. Bathroom issues have never been ideal, but the last 2 months, very bad. Nausea and flushing too. This is not the first time I've had episodes like this. Sorry to hear that, Amy. And then Amy says, my question is, can carcinoid syndrome go undetected with the testing? So let's talk a little bit about carcinoid syndrome, exactly what it is.
So carcinoid syndrome is a collection of symptoms. And so we call it a syndrome because it's not just one thing. So the most common symptoms would be the frequent diarrhea, flushing, which affects both men and women. So the sensation of having hot flashes, and hypotension or low blood pressure, feeling lightheaded, unsteady on your feet. And some people are not affected so much. They may have relatively mild and manageable symptoms. And as I mentioned before, other patients can be extremely debilitated by it. And the reason we measure these levels in the labs, 5-HIAA and chromogranin, is that they can be an indication of the tumor burden, how much tumor there is, and that would be suggestive of how much disease there is in the patient's body. Usually, the higher the levels, more likely the patient is to be suffering from symptoms and things like that. And it most commonly occurs when the patients have diffuse involvement of the liver, because the liver breaks down these compounds. But when the liver has a lot of tumor or is essentially replaced by tumor, it can't break these compounds down, which is why when we measure them in the level, they're elevated, because the liver can't do its job of metabolizing and breaking down these levels. So that's why we were able to use them as tumor markers, which generally correspond well. What's odd is that sometimes we have patients who are extremely symptomatic or extremely syndromic and are suffering terribly from their symptoms. And yet we look at their liver, or we look at their scans outside the liver, and we don't see a lot of tumor burden. So then the question is, why is this going on? So things don't always make sense to us as far as all the data we can put together. So then we just kind of have to figure out how we can manage if we need to do other kinds of scans. I mentioned before the FDG PET-CT scans. When the tumor starts behaving badly and changes gears, it may start showing up better on an FDG PET scan, which is why some of you or many of you may have had both types of PET scans. You might see disease only on the PET scan that we don't see on the dotatate PET-CT scan, or we might see tumor burden on both scans. So any combination is possible, and that may explain what is going on with patients.
Got it. Thanks for your question, Amy. Hope you feel better soon. Next question. This is another one from Jolene, and it is indeed Jolene. She indicated, do you understand why tyramine foods cause symptoms to become very severe? If not, what kind of doctor would know about this type of reaction? And in parentheses, no medications are involved.
Tyramine. I probably should know the answer to this, but to be honest, this is probably in the wheelhouse of a medical oncologist, and I'm sorry, I'm embarrassed. I probably should have some kind of educated answer to that, but I'm stumped.
No.
Something to do with the liver's ability to break it down or not. I could be wrong, so I would suggest that perhaps a medical oncologist could provide a more informed answer to you. So I apologize, Jolene.
What about nutritionists? Yeah, because I know that's come up a lot, Jolene, in previous Luncheon with the Experts that we've had and other videos that we've done. And so we've had some nutritionists on the show that have talked about that. So if you go through the archives, the video archives for this show, you can see some of those, and we've talked about that. It was a while back, so I don't remember or recall what they said, and I don't want to misrepresent anything, but that might be helpful as well. Next question from Rebecca. With small intestine nets, do we need an endoscopy to keep an eye on it and help prevent small bowel blockages?
Well, you can do some endoscopy. So with an upper endoscopy, you can get into, I think, the duodenum and maybe proximal jejunum, which is what we call the proximal or nearer part of the bowel. You you can't pass the scope too far down into the small bowel as far as a manual scope. We do have such things such as capsule endoscopy, and so that may be useful for surveilling the small bowel to look for things. But in my experience, we tend not to use that so much. It seems to be that more frequently patients will present with abdominal pain, and upon imaging, we'll see something that looks like obstruction, that may require surgical intervention. But that's a good question in terms of, why, or that raises a good question in terms of why we may not use that technique more frequently than we seem to.
Got it. Thank you. Folks, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We have just under 20 minutes left. I see some of y'all. We have great numbers today. I see some of y'all have been tagging people in the comments as I requested in the beginning. Thank you for that. We appreciate your help in getting people here. And lots of people chimed in earlier with value is always. Love to hear that. Next question from Tania. Hope I'm pronouncing that correctly. If so, Tania says, I had PRRT at the end of May 2019, and I have more liver metastases. When am I eligible for more PRRT if that is what is indeed decided?
Right. So I would suggest that if you've had a more recent dotatate PET-CT scan, that would be used as kind of a screening tool to select patients who might be eligible. So what we look at when we look on these scans is to see how much uptake there is, meaning how hot the lesions are. And the hotter it is, the more likely somebody is to benefit from the treatment. So if you haven't had one recently, then I would suggest that perhaps you need a repeat scan, and that your physicians could use that to help them decide whether or not you're a candidate for repeat PRRT.
Got it. All right. Thanks. I hope hopefully that helped answer some of your question. Amy says, how often does this change occur from well differentiated to poorly differentiated?
So it may not, Amy, that's a good question. It happens, and it generally doesn't take a leap from well differentiated to poorly differentiated or even undifferentiated. What we see is we follow the patients, we look at their scans, we look at their blood work, and if there's some kind of sudden change in the patient's tumor burden, that might trigger a biopsy, and the biopsy might show that the tumor is starting to dedifferentiate. So one of the bits of information we can get from biopsies is what's called a mitotic index, which is something that indicates how fast the tumor is turning over and the cells are replicating. So when the tumor is well differentiated, that mitotic index or proliferation index is very low. And when we start seeing the numbers, so it's usually expressed in percentages. So like 1%, 2% would be low. And if that's what you start out with, that's great. Hopefully it stays that way for a very, very long time, if not forever. But not uncommonly, we'll see that patient seems to have stable disease for a period of a few years, several years, then something changes suddenly. And when we biopsy something that's new or gotten much larger, we may discover that it's the same tumor, but now the proliferation index is now 12%. You know that the tumor has started changing gears, and that might be a reason to start thinking about other therapies. If we don't see the tumor very well on a dotatate PET-CT scan, we might try an FDG PET-CT scan if that might confirm our suspicions or concerns that the tumor has switched gears. And if the tumor shows up very well on the FDG PET and not very well or not at all on the dotatate PET, then we know that we're dealing with a different animal. It's not the same thing that you started out with.
Mm-hmm.
And PRRT is likely not going to be of any benefit to you. So the PRRT, the dotatate PET-CT scans are kind of used as proof of concept tests to show whether or not you're likely to benefit from the treatment. And if your tumor, we know, it has progressed, that you have a larger tumor burden, meaning the tumor mass, wherever it is, it's much larger than what you had fairly recently, and it doesn't show up very well on a dotatate PET-CT scan, that would be, unfortunately, a poor prognostic indicator that you're not likely to benefit from any type of somatostatin analog therapy, radioactive or not, and that other therapies, likely more toxic therapies like chemotherapy or maybe immunotherapies, may be what you need to try to get you some kind of response.
Got it. Thank you. Next question from Michael. Is moderate alcohol use a problem while on a somatulin depot for liver mets?
It probably doesn't help the situation. So we know that alcohol is a toxin for the liver. I think the American College of Cardiology has just recently released some guidelines recommending that people refrain from alcohol, that no amount of alcohol, so even alcohol in moderation, is not safe. Although recognizing that that's unrealistic to expect that people will abstain totally from alcohol. Mm-hmm. But the recommendation is to drink in moderation. So I think adding a toxin to your liver, exposing your liver to a toxin, if it's already diseased with tumor, is probably not going to be beneficial. And I think there's the adage that booze and pills don't go together very well, something like that. So I don't think you would be helping your situation by certainly consuming excessive amounts of alcohol with your treatments.
Got it. Thanks, Michael. A few other people were curious about that. I know that's a tricky tightrope walk sometimes, but he did mention moderate alcohol use, so I think he's aware of that already. Next question from Linda: Do you see this disease often in the brain?
I think rarely we do see brain metastases. More commonly, what we might see on a scan is something that suggests that maybe the tumor has gone to the brain, and we have what we call these things referred to as false positives. Mm-hmm. See something on the scan that's abnormal, and we may or may not be able to tell exactly what it is. So with PET-CT scans, we may not have the resolution to discriminate something that's at the surface of the brain, just outside the brain, or in the skull. And we have these tumors, they're generally benign tumors called meningiomas. And if they become calcified, then we might be able to see them because they're dense. And we may be able to see them between the surface of the brain and the inner layer of the skull, in which case we can say pretty confidently, oh, that's probably a meningioma. Mm-hmm. But the meninges is the outer covering of the brain. And so you may appreciate that the brain is a complex structure, and so the covering is also complex, and it may exist, meningiomas may occur in other places where it's really hard to figure out whether it's in the brain or not. So it may require additional imaging, like an MRI, and they may be able to say with greater confidence, okay, it's in the meningeal layer, and therefore it's likely a meningioma, again, which is generally a benign tumor. And what's interesting is that they're looking at PRRT as a treatment for meningiomas. So, but as far as metastases to the brain, they do occur rarely, so we don't see them very much. We're more likely to see meningiomas, which would be considered a false positive or a red herring for something like a brain metastasis.
Got it. Next question from Tina. What are considered high levels of chromogram? And if my levels go up and down, is this normal?
So I don't recall the top of the normal range off the top of my head, since that's not something I follow myself. Or medical oncologist or surgeon may be more likely to follow that than I would. So I can't answer, what's considered a high level other than above the top of the normal range. But we do see lab levels fluctuate, and they may, go up and down in a relatively narrow range. They may be considered outside of the normal range, but that may be normal for you. So the normal ranges are derived from a population. And so if you remember the bell-shaped curve, everything that falls within 2.5 standard deviations from the mean is considered normal. And so then you have 2.5% on each side, on each end of the bell-shaped curve, where other data, other people may exist and would be considered too low or too high according to the normal range, but might actually be normal for that particular person. So your chromogram level might be fluctuating. It might be slightly elevated, but that potentially could be normal for you. I'm not saying that's the case. I think that question would be best discussed with the people actually taking care of you.
Got it. Thank you for that. Folks, we got time for just a handful more questions. It's a little more than 5 minutes, but we're going to keep moving forward so that we can get as many as possible. David says, are there any labs or tests that my sons could have done that would identify NETs in the early stages before any real symptoms develop?
Lab test is this for somebody who has the diagnosis, or is this somebody who, as a screening tool?
It feels to me like a screening tool. Are there any labs or tests that my sons could have? So mentioning both, so that leads me to believe that maybe David has one and he's concerned, because we get questions about like,
right,
any genetic testing often. And let me know, David, if this is accurate, if I'm representing your question properly. But so he says, are there any labs or tests my sons could have done that would identify NETs in the early stages before any symptoms develop? So I'm not entirely sure, but that's what I'm led to believe.
We have these familial syndromes. They're called MEN syndromes, multiple endocrine neoplasia syndromes, and there are different types. We have different kinds of tumors. Sometimes they're benign. Sometimes some of them are benign, and others are malignant. And so I'm not aware of any labs that are used to kind of screen for the potential to predict the onset of anything like that. Perhaps a geneticist might have a different answer. But generally speaking, all these labs that we've been talking about, 5-HIAA, chromogram A, as far as I'm aware, they're not useful for diagnosing tumors. So for instance, PSA, prostate-specific antigen, is a level we follow for the patients who have the diagnosis of prostate cancer, and we can kind of use it to screen patients, recommend it as a routine sort of thing, the way we recommend, for instance, routine mammography for women, or routine colonoscopies after the age of 50. Um, so if we measured these labs in your children and they were abnormal, I myself wouldn't be sure how to interpret those things, because most often they're what we call non-specific. We mentioned a differential diagnosis before, so there may be a longer or shorter laundry list of possibilities that might explain an abnormal value that may or may not be related to, one's worst fears, a cancer diagnosis. So we had the question before about something that you eat, or medications, or other conditions, benign or malignant, may all be potential explanations for an abnormal lab value. So I'm not aware of using these labs as a screening method to try to predict an oncoming diagnosis of a neuroendocrine tumor.
Got it. Thank you. Okay, I have a big, broad question that I have received before. I know people are interested in this, but we'll see how you feel about this. Rebecca says, "What causes NETs, and how can we prevent it?" So I understand that's a big question, but a lot of people are just like, where does this come from?
Right. To the best of my knowledge, it's what we consider a sporadic tumor, meaning that it just happens. So I'm not aware of any specific risk factors for development of neuroendocrine tumors specifically, other than the familial syndromes, the MEN syndromes, the multiple endocrine neoplasia syndromes. So if you have that family history of an MEN syndrome, in that situation, you do screen family members for the potential of them also developing an MEN syndrome. But as far as exposures to avoid, environmental exposures, occupational exposures, lifestyle, I'm not aware of anything that may trigger neuroendocrine tumors. Mm-hmm. The general thought is that if you have a healthy lifestyle as far as what you eat, we talk about food as being the most important drug that we put in our bodies. If you're eating a lot of processed foods, I think there's good evidence to show that that's not good for you. If you eat a lot of bacon, if you eat a lot of hot dogs, if you eat a lot of red meat, if you eat a lot of grilled red meats, that's not helpful for you, which is bad news for me because I'm particularly fond of those things. So if you eat a plant-based diet, maybe organically grown foods and proteins, these may be beneficial for you. If you're active, I think there's good evidence to show if you're active, you're more likely to be healthy than somebody who is sedentary, again, like me. So what happens is if you're regularly getting aerobic exercise, is that your spleen, which is kind of a reservoir for white blood cells, will release those white blood cells into the circulation. Mm-hmm. So instead of sitting around waiting for pathogens, including potential cancer cells, to pass by for them to try to catch, the white blood cells will be more actively on the hunt. So those white blood cells will switch from a more passive kind of posture to an active posture, going out on the prowl in your circulation, looking for anything that might be bad, that might be harmful to you. And there's a greater potential for an effective immune response. So we do know that cancers grow and more often grow in patients who are immunocompromised. So patients who have diabetes, patients who have some kind of immunocompromised syndrome, such as HIV, people who are transplant patients who are on anti-rejection drugs, immunosuppressive drugs like steroids, they're going to be more prone to forming different kinds of tumors. So, and there's a phenomenon that we refer to as post-transplant lymphoproliferative disorder. So patients more commonly develop some type of hematologic malignancy, meaning some kind of blood-based cancer like a lymphoma or leukemia after either a solid organ transplant like heart, liver, kidneys, pancreas, lung, or bone marrow transplant. So getting exercise is good for you. So those are the things that I can suggest, and be happy, right? Stress probably doesn't help. So if you're really stressed out because of life circumstances, if there's a way you can achieve some calm, that will decrease your cortisol levels. Your adrenal glands won't be pumping out the cortisol, which is also kind of an immunocompromised state. When you're really stressed out, you're less able to fight off infections and potentially also tumors as well. So if you can achieve calm, if you can achieve some measure of contentedness or happiness, I think that would be beneficial for you as well.
That's great overall advice. I appreciate that. Folks, that's our show for today. Rebecca says, prayers for all fellow zebras and their caregivers. Thank you for these Lunch and Learn lives. They are so useful. Appreciate you and all your guests that educate us weekly. Well, Rebecca, that's what we're here to do. We appreciate you as well. And we certainly appreciate this week's guest, Dr. Daniel Lee. Dr. Lee, thank you so much for being here and sharing some time and wisdom and information with us all.
Thank you for this opportunity. I enjoyed it.
Absolutely. Absolutely. I know that people, they told me, in fact, that they received tremendous value today as I prompted them to. And so, folks, we appreciate you as always for being here. We hope this program helped answer some of your questions. I'll reiterate, if you have follow-up questions, reach out to CCF either here. You can private message them, or carcinoid.org. You can shoot them an email. Thanks again, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. Without them, we couldn't do the show. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.